Well, thank you, and thank you so much for the roundtable organizers for inviting me to speak with you today. I think I did not want to do that. Let's go back. So we're going to change gears a little bit now and sort of pull back the lens and think about more what's happening in populations. Obesity has been called first epidemic because of its rapid and dramatic rise, but later called pandemic as we came to realize that there really are no population subgroups who are not affected by changes in obesity. But we know that across the population, the distribution of obesity is not constant. Obesity disparities, like other health disparities, are seen by groups defined by social, demographic, environmental, and geographic characteristics, as are its determinants, notably physical activity. These are groups that have experienced bias, discrimination, and stigma, with resulting social disadvantage and marginalization, which are reflected as poor health, being in that unregulated zone. Such health disparities are at odds with ideals of social justice and of health equity. So we have seen today ample evidence to show that physical activity is an essential component of health and well-being. But with that evidence, we need to think about equitable access to physical activity opportunities with appropriate adaptations and understand how these can contribute to all groups achieving the highest level of health possible. So how might social disadvantage limit physical activity? So the most simple way would be in lack of access to material resources and time resources needed to engage in physical activity. But thinking about environments and the extent to which stressful environments can induce depression or are embodied as depression and how that may influence the uptake of physical activity. The extent to which racial discrimination and segregated neighborhoods create environments in which there's little investment in open space or facilities to promote physical activity. And of course, reduced access to primary care and preventive services. So the extent to which we see obesity and physical activity disparities is going to vary over some key dimensions. And the ones we're going to look at this morning are not all of them, but these are the major ones of interest. We have gender, immigration status, socioeconomic status as reflected by income and education, and geographic location, both in terms of where in the United States someone might live and also the degree of urbanicity or urban-rural status. And disability, based on the increasing awareness that disability, apart from its physical underlying manifestations, is actually a social experience, and that persons with disability experience the same kinds of social marginalization as do racial and ethnic minorities, as well as its consequences: lack of resources, lack of power, and lower social standing. So as an epidemiologist, we're going to be looking at some nationally representative data to just look at really what are these patterns of obesity disparities and physical activity disparities. So these data come from NHANES and show the progression of the prevalence of obesity across the various life stages. And you can see that what's striking is the increase with age until about age 60, where there's a moderate decline, but still very, very high rates. You don't see large gender disparities in obesity. In terms of racial ethnicity, race, ethnicity, and sex distributions, we see, again, lower rates in children with disparities by race, ethnicity, as we're all aware, higher rates in blacks and Hispanics, and actually lower rates in Asians. For adults, a similar pattern is seen with higher rates in blacks and Hispanics compared to whites and lower rates in Asians, but what's most striking are the very high rates in African American women. I also should comment on issues of data equity, because we don't know much about other groups, and even Hispanic subgroups, where we know there's a lot of differences between these subgroups. We know most about Mexican Americans because they are the largest group and therefore the most studied. Thinking about the physical activity side of disparity, these are data also from NHANES based on accelerometry, so objectively measured total activity minutes. And you can see for youth that there's a rapid, really striking decline of accelerometry measured minutes for from 6 to 11-year-olds down to 12 to 15-year-olds and 16 to 19-year-olds. The purple line, the purple horizontal line, shows the 60 minutes that are the recommendation, and you can see that only for males overall and for the youngest children are those groups meeting the activity recommendations. Also notable is that there's very little variability for the three racial ethnic groups, so that racial and ethnic minority groups, or at least the major groups in the United States, are not getting less physical activity in terms of minutes of moderate and vigorous physical activity. So these data are now coming from self-report, so it's a slightly different situation, but these are data on adults and show the extent to which different groups are meeting the guidelines for physical activity. And so the first thing that's, I think, quite notable is how low the rates are, so that you have only 20% of adults in most groups, 20 to 25% meeting those recommendations, with some variability across groups, but not large differences. Again, these are self-report data. We don't have good accelerometry data on population subgroups beyond the major ones. And we've talked a little bit this morning already about inactivity, getting no physical activity. And here you see more variability across race, ethnicity, with blacks and Hispanics being more likely to get no physical activity compared to whites, and some variability among the other groups that are shown here based, again, on self-reported data. So the epidemiologic data show us that there are very low levels of physical activity, but they tell us very little about culturally determined attitudes towards physical activity and the extent to which those may actually be acting as facilitators and barriers. There's some qualitative work that shows that cultural norms don't support strenuous activity for girls in some Asian and Hispanic cultures. Other qualitative data have studied African American women who indicate that putting the needs of others before one's own is actually a cultural barrier to physical activity. So taking care of oneself is not necessarily what the culture supports. And on the positive facilitation side, in certain Asian cultures, physical activity is viewed as part of staying in overall balance, and so it's very much part of daily life. So we obviously need to know much more to understand what's happening with respect to individual level factors. Moving on to looking at disability, this slide contrasts the rates of obesity for persons with adults with disability compared to the major racial ethnic groups, and you can see that these are not mutually exclusive. Some of these people with disabilities are of the various ethnic groups, but you can see that rates of obesity are actually quite high, higher than for even African Americans. And in children, disability is also associated with higher rates of obesity. And these are data from the National Survey of Children's Health that shows, compared to all children in that survey where obesity rates are shown in this dotted line, that children with hearing and vision, learning disabilities, developmental or physical disabilities, autism, or ADHD are all at elevated risk. And not surprisingly, given the unique needs of persons with disability, particularly mobility disability, minutes of MVPA are far lower for people with disabilities compared to those without mobility disabilities. But I guess what's most striking is the size of these bars of 28 minutes for those without disability and 12 minutes of MVPA for people with disability. So it's horrible for everybody, but much worse for people with mobility limitations. Clearly, meeting the unique needs of individuals with disability in terms of regular physical activity is a priority. It takes special equipment, special training of the people who work in schools and at YMCAs, but it's extremely important given the high levels of obesity. So moving now to immigrant populations, you can see that years of residence in the United States, which is considered a marker for acculturation. You can see as you go from less than 1 year up to 15 years that rates of obesity increase, so that at 15 years you're getting close to the obesity rates seen in the U.S. Born population. So immigrants actually come to the United States with better health habits than they acquire once here. And but they generally acquire some of the habits of the population in which they find themselves. So this is actually somewhat surprising and counter to what one might expect. These are self-reported data from the National Survey of Children's Health that show that regular physical activity actually increases as you go from being foreign-born with 2 immigrant parents to U.S. born with 2 immigrant parents and then U.S. born with 1 immigrant parent, that your regular physical activity actually increases and the likelihood that you will participate in no sports decreases. So this is a situation where it's not necessarily as you might expect. I'm very fond of this particular slide because to me this is an immigrant woman in a vacant lot littered with garbage, painting a mural that I think is depicting soccer, which might have been part of her life in the country from which she came, but is no longer something that she has access to. The situation with socioeconomic status is actually a little bit complicated, especially with respect to income and by sex. So what you see on this slide are that for white women, shown here in the mustard-colored bar, that as you go from below poverty to near poverty to higher levels of affluence, that obesity rates decline. An embodiment of the statement, you can't be too rich or too thin. For the other groups, non-Hispanic blacks and Mexican Americans, it's more variable, and you don't see that, that same relationship. Even more complex, I suppose, for men is you see for white men the same inverse pattern, although not as striking for men as for women in white men, but for non-Hispanic blacks and Mexican Americans, you actually see increasing rates of obesity as you go from poverty to affluence. So income is a little more straightforward with respect to physical activity disparities. As you have more and more assets, you have higher likelihood of meeting the physical activity requirements. Again, these are still pretty low levels, from 14% to about 26%. So nothing to write home about, but certainly income helps. What these data don't tell us is what aspect of having financial resources are at play. Is it the ability to buy nice bikes? Is it the flexibility of work schedules that give you the time to engage in physical activity? Or is it the knowledge that prioritizes health-related behaviors? This is a picture of kids at recess, and the extent to which policies are also not distributed equally across different population income groups. So these are data that come from the ECLS-K, and what's tabulated here is having access to some recess, and these are clearly, recess is a policy that schools take on or don't take on, and you can see that for children who are white, their access to recess is actually pretty good compared to children who are black and Hispanic, and similarly, low-income children are less likely to have access to recess. So the policies also show these same kinds of disparities. And then the famous CDC maps, about which we've learned so much, show us that the highest prevalent areas in the United States are the Midwest and South. And when you look at how percent of adults meeting the physical activity guidelines map to that, you actually see they map quite well with the states where there are the lowest percent of people, of adults meeting physical activity guidelines pretty much overlay the groups, the states where there are high rates of obesity. And finally, urbanization level is associated with obesity prevalence. So what's shown here are 3 categories of metropolitan counties, large central, which would be inner city, large fringe, and small metro. So these are all metropolitan counties, and then more rural counties where you have small towns and then fully rural areas. And we haven't really talked that much, and there's sort of a renewed focus on thinking about rural environments and the extent to which there are specific unique barriers to physical activity. But you see here that the prevalence rates are far higher in the more rural areas compared to the urban areas. What's tabulated here is prevalence of inactivity or no leisure time physical activity among adults, arrayed exactly the same way. And you see a pretty similar pattern with the rural areas having more people who get no physical activity at all. The exception here is that there's some elevation, especially for females, in the inner city. So increasingly, we're aware of the extent to which the built environment influences physical activity. Many aspects of the built environment have been studied: sidewalks, the accessibility to parks and recreation, bike lanes, even the lighting in at intersections. And this is an area where I think we have an ability as a public health community, and also from all of the seats from which you sit, to really influence the physical activity patterns of people in important ways. I would be remiss to not share this one slide that attempts to look at the availability of physical activity facilities and overweight from the National Longitudinal Survey of Adolescent Health, where the researchers actually drew buffer zones around the residences of each subject, and were able to show that as the number of physical activity facilities increased, the odds of actually getting 5 or more bouts of MVPA per week increased by about 26%, and simultaneously the odds of being overweight decreased by 32%. So achieving physical activity equity should be a goal. The extent to which the patterns of physical activity and obesity disparities map really isn't what's important. As we've heard from the earlier talks this morning, it's important that people become active, and the barriers that socially disadvantaged groups face in getting physical activity are far greater, and getting from the unregulated zone to the regulated zone will be a longer journey. I did want to again reference the wonderful commentaries that were written talking about some of the issues in these population subgroups that are part of your programs today. So I hope that this conversation about physical activity patterns and disparities will stay in the back of your mind as we look at some of the studies that are being done linking physical activity to obesity in the population. Thank you.